Well, good afternoon, everyone. I'm here with the Military Officers Association of America's president, Lieutenant General Atkins, to talk about VA's response to the COVID-19 pandemic and how we can better serve our veterans throughout this crisis. A big thank you to MOA and all of your members. We're grateful to have you here virtually, General Atkins. I wish we could do it in person, but the circumstances warrant us to do it from a distance. I want to first give a brief update on what the committee has been doing with the VA's top administrators. The committee is still getting slide decks from the VA with facility level data on the number of veterans and employees that have been tested, how many veterans and employees have tested positive, and what the PPE levels are. Additionally, last week I asked VA for the data on minority veterans who have tested positive for COVID-19, specifically since we know that they've been disproportionately impacted by this crisis. We also have weekly calls with both the Secretary and Dr. Stone related to the department's response to COVID-19. As I'm sure you're aware, we're pressing for more transparency throughout this crisis. And what's more important right now is that we know what VA absolutely needs for their to keep their staff and their veteran patients safe. And that's why I wanted to have a talk with you today, General Atkins, and to see how it is that we can help, how you and MOA and my committee staff and I can be of help. First of all, I want to ask how you are doing personally, General Atkins. You are doing well and safe and healthy?
Well, Chairman, let me back up a little bit to thank you. Thank you for your leadership and certainly the committee's leadership in supporting our veterans and their families. I'm doing great. We made a conscious decision almost 2 years ago to invest in technology that allowed us to go into this kind of telework environment that we've all been kind of navigated into. And we believe that our transition from being on site at our headquarters in Old Town Alexandria to this virtual environment has been both transparent and no loss of productivity for our association. So we're doing great. And you're going to ask me some questions about, what are our veterans saying? And one of the things we invested in was an online web-based reporting tool. So we get pretty active reporting from our veteran population, either in some cases to our own inquiries, but some cases self-initiated by them based on their own experiences. So I'm happy to be able to discuss those with you today.
Well, great. That was fortuitous that you all decided to make these investments in technology. I have a feeling that one of the consequences of this pandemic is that a lot of our daily lives and our work lives are going to be changed, maybe permanently.
I agree.
Even as we get past this pandemic, we're learning to work in different ways, and we're actually finding there may be better ways to work. So what are you hearing from your membership? What seems to be their top concerns?
Well, I would think our members pretty much mirror, I think, what you're hearing broadly, not only across the veteran community, but really across our nation. Significant anxiety, based on the evolving economy, or at least the financial position of our economy. Significant anxiety and stress that has been brought on by, in some cases, unemployment or the uncertainty of the pandemic itself. So that kind of continues to resonate. I think that the big concern that I hear really is in the medical healthcare arena. Our many of our veterans, particularly retired veterans, have found themselves in locations by choice that offered a medical treatment facility. You and I talked earlier about Army Medical Center. Somebody might have chosen Hawaii, as their home of record beyond their military careers because of remarkable healthcare access that they would have at Tripler. And so the big concern now is an ongoing effort from DOD and Defense Health Agency to modify the military treatment facilities. In some cases, closing nearly, I think 47 is the number that I've heard. And in some cases, restructuring some medical treatment facilities so that they're just kind of walk-in day clinics. So the access is gone. But what happens is that you've now forced that beneficiary population to kind of go out on the community and get community care now versus through a military healthcare system. And so the dilemma here is, are those communities, are they ready to absorb this patient population? And right now, the estimate with 47 medical treatment facilities being divested is that we're going to put about 200,000 beneficiaries out on community care programs. And right now, our assessment is that DOD or DHA, the Defense Health Agency, hasn't done the appropriate assessment of those communities to absorb that patient population. They may say, well, yeah, there's a amount of family care practitioners or OBGYN or whatever it is, but will they in fact take this new patient population? In some cases, the answer is going to be no, because the TRICARE reimbursement fees are well below what those physicians can actually get from other healthcare insurance companies, et cetera. So we're concerned about that. The other part is an ongoing effort to downsize the military health system workforce by about 18,000 individuals. In the military, they call them billets, but 18,000 billets. So again, what we've just witnessed with this pandemic is this whole of government approach to addressing the pandemic. And DOD is part of that. The VA is part of that. So we are asking Congress to, hey, let's go back. Let's take a look and make sure that we're assessing the capacity of this military healthcare system under the same constraints that we're facing today with this pandemic. Now, many would say, well, yeah, this is like the 100-year flood. We're not going to have this all the time, and this is not a normal setting. But the reality is our nation has to respond, whether it's a 100-year flood or, it happens again later this fall. So we're asking Congress right now to relook the military treatment facility reform, and also the reduction in nearly 18,000 billets to the medical healthcare system. That seems to be the real key issue right now with our veteran population.
So let's dive a little deeper into this. Sure. In Hawaii, Tripler is a joint facility, as I recall. I visited it last year. It's in a beautiful setting, but it's an Army hospital that's sort of co-joined with a VA facility, so it's a joint facility. So the consequences of what what Department of Defense is doing, now on the surface, I might think, well, since it's a joint facility, the actions the military is taking with regard to its facilities probably is not going to impact the veterans on Hawaii so much, but maybe not, because some of these retirees may not be enrolled in the VA medical system. They may be relying on TRICARE. And Hawaii is, I don't know what the saturation point or what the density of care in the community is, and whether they will, but there are others. So there's a VA facility there in Hawaii, right, which many of those retirees could go in and enroll in the VA, but many might not be eligible for VA. And so they are stuck with their, not stuck, but they're left with their TRICARE benefits. And are we thinking that the TRICARE beneficiaries, even in a place like Tripler, might not be able to use Tripler anymore?
Yeah. Now Chairman, I don't know that Tripler is probably the best example because I don't think Tripler is one of the installation that is on the, kind of the list, to basically be divested.
There are others, but there's others in the Carolinas.
Oh, yeah,
I've read
absolutely. Across the nation. Yeah, across the
across
nation.
the nation, and as you said, people might have located in these communities because they knew
Right.
that there was a
Yeah,
healthcare facility, a military healthcare facility there that they could use.
absolutely. And now let me give you as an example. So I am a retired veteran. I actually used up until age 65, I'm now 66, but I used TRICARE. I used what they call TRICARE Prime at the time, meaning that I could go to a medical treatment facility to get my medical care, as did my wife. So in Washington, D.C. area, I chose Fort Belvoir, which was a convenient location. The care there was remarkable. I mean, I have absolutely, nothing but accolades to say about the care. But now, under these new restrictions, let's just say if Fort Belvoir is one of the closure MTFs, then I'm going to be asked to go out onto the community and find community care. Find a physician now that's going to take care of me and my family, because the hospital, in fact, cannot and will not do that going forward. So the dilemma though now is, okay, now can I go find that doctor? Can I go find that Dr. Takano who's going to take care of my family? And the answer might be, well, yeah, there's a lot of Dr. Takanos out there, but will in fact they take you as a new patient? In some cases, the practitioner is going to say, no, I'm full up. I can't take another patient like this. Or the other one would say, you know what, I'd like to see you like this, but you're going to come to me and you're going to ask for TRICARE reimbursement rates. And those reimbursement rates are at the bottom of the bathtub, like this. And I can take another beneficiary. I can still do my, Hippocratic oath and take care of somebody, but get reimbursed, and my staff get reimbursed, and my business get reimbursed at a level that far exceeds what TRICARE would reimburse me. So that may be something that we'll have to look at. We as a nation will have to look at if this continues to go forward. What in fact are the TRICARE reimbursement rates, and are in fact they competitive, so that you will in fact entice a physician to take on additional beneficiaries.
Well, that's one. And tell me, explain, is VA care, is care at a VA or in the VA system not really a solution for these TRICARE beneficiaries, because they may
Yeah,
not,
it is.
they might not qualify for the VA.
Yeah, in some cases, there may not be a VA facility that's, just co-located or conveniently located, or it may be, a long ways away. So, I mean, there's not, like I say, there's not a VA, medical center in every city in the nation like this. So you might have somebody, and I believe you'll find the impact of this probably more in the rural settings, or you'll find it where we've had bases that have, in fact, in some cases, have been part of a previous BRAC process that don't have a military presence there anymore. And so somebody's not going to have what I would call, expedient type of access to a VA facility. And I think the VA is doing a great job. I mean, I'll be very honest with you, even through my lens, I would say years ago, walking into a VA medical facility was the last thing I wanted to do. I mean, it was dark, it was dungy, it had a musty smell to it. I was down in Augusta, Georgia in a previous position in the Charlie Norwood Center in Augusta, Georgia. I go, oh my gosh. I mean, it reminded me of, and I don't mean this in a very derogatory manner like this, but One Flew Over the Cuckoo's Nest. I mean, it just reminded me of that scene, of Jack Nicholson, in that hospital. It just had an unfriendly feeling. But I know the VA's made remarkable strides in making, kind of their facilities certainly more welcoming than they've ever been in the past.
Well, thank you. And I've toured many, not all of the 170 medical centers, and seen some of the CBOCs out there. And, I can attest to that. I think things are not the way that they were. And of course, I'm committed to making sure that we continually upgrade the quality and experience. And it's borne out in independent studies like the RAND Corporation, and there's been other types of surveys which show that VA healthcare in most lines of service is on par, if not better, than what's
Right.
offered in the private sector. I'm glad we touched on this issue a little deeper on TRICARE and military treatment facilities. I think we're going to have to really take a close look at that, both my committee and the Armed Services Committee. Let me move on to another issue. What have you heard from your reservists and members of the National Guard about deployment in support of COVID-19 response? So a lot of your members are reservists and National Guards, men and women. They've been called in to support the states in the COVID-19 response. Have you heard concerns about deployment as a part of the counter protest measures as well?
Yeah. Chairman, I think there are probably two things that probably have resonated, and I would kind of capture one under, I would call it standardization. And I'll use an example of a reserve nurse in Southern California who got called up for COVID-19, and during the course of her deployment over, I would call it, other phases of the pandemic response, she was going to multiple VA facilities. And each VA facility had a kind of, I would call it, a different standard in, what you were supposed to wear as far as personal protective equipment and what were the protocols. And so the frustration was, why can't we standardize this across facilities? And why can't the PPE ensemble that I would wear at this facility, why wouldn't it be the same as at that facility? And so, but I think that has been recognized by the VA, and I know Dr. Stone and his staff have worked, I think, pretty hard to basically standardize that. The other one is, and again, response to COVID-19, and I would say that the bigger part was, it's the earned benefit piece of this thing. I know there's some congressional action right now to find legislation so that individuals that do deploy in response, Guard and Reserve, that deploy in response to COVID-19 do get their earned benefits. I know there was some debate, over 89 days,
Yeah.
1 day short of having, the amount of days, the 90 days for benefits. I saw that the House bill, I think a couple of days ago, my staff shared me that House bill. And one of the things I said in there, let's make sure that we convey this back to Congress, there has to be some sort of minimum in there too. You can't, again, I remember the days when we would deploy in support of, Iraq, Afghanistan, et cetera. If you were there on the last day of the month, you would get combat and hazardous duty pay. And if you were there on the first day of the month, you would get combat and hazardous duty pay. So people would often, artfully, on a short deployment, make sure that they were there on the last day and the first day, so they get 2 months of benefit when they were really only there for 4 days. You see what I'm saying? There's a
kind of a gaming of that system.
Yeah. So I said, make sure that if we do this legislation, and we do have these earned benefits, there's no gaming. Somehow there's some filters or some
guardrail. We have some guardrails on it. Yeah.
Yeah, exactly. Because otherwise somebody could say, hey boss, deploy me, for a week down here, and then I can turn in, and I can get credit for 90 days and get benefits and retirement benefits, et cetera, like this. So I just don't want people gaming the system.
I hear you. But it does not seem fair that people, reservists and guards and members of the Guard, they've been sent out to, respond to the COVID-19 in various ways, and they're at 89 days, 1 day short of being able to qualify for certain GI Bill benefits.
I fully agree with you. I think we fully agree with you.
That was raw. Yeah. And I think my sense is that Mr. Levin's bill, the Reserve and Guard Parity Act, is garnering some bipartisan agreement, and I think even the administration is they decided to take a second look at that 89-day issue.
Right. You know, the last one, Chairman, the last one obviously is, you know, and this is more, you know, we talked about Garden Reserve, but, you know, in protest response, you know, we've gotten a few of our members that have certainly called in, asked to talk to me, you know, what's our position, what's Mo's position on the president for, you know, perhaps, you know, enacting the Insurrection Act and then using the military. I mean, there's certainly some, you know, I would call it division out there in even in our own membership about that. I wouldn't tell you that I have a position or Mo has a position other than we have had some members call in concerned over the potential implementation of the Insurrection Act.
Well, I appreciate that. And of course, I'm very apprehensive about it. And I realize that you are in, you know, as a leader of the organization, you'll have your own process. As things unfold more, you know that General Mattis has come out with a statement, and I think the former Joint Chiefs head of the Joint Chiefs of Staff. So anyway, I'm horrified at the idea of active duty troops being deployed, and I would prefer to see the governors work it out and be given a chance to ensure the safety of their citizens in the way that they're doing.
Right.
What updates are you getting from VA? Do you feel like that you and Mo are getting all the information you need in a timely manner?
You know, Chairman, I think the last time we talked in March, you know, I mentioned that it always can be read. I mean, you know, communication can always be better. Even communication between husbands and wives can always be better like this. But I think the VA, the Secretary, Dr. Stone, and Paul Lawrence have all stepped up, and they've done a great job, I think, of really communicating in a better way. I would tell you that I still believe it's a bit mechanical. You know, we're asked, you know, a week in advance to submit your questions. And then it's kind of a, hey, we're going to answer your questions, but there's a little bit of lack of, I would call it, engagement and dialogue. I mean, they're always at the end of the meeting is, you know, do you have some questions? And you know, sometimes you could, you know, be held hostage by somebody who has a strong personality and doesn't give up the mic. And so, but I think they've done a great job. You know, they've kind of advanced their text messaging to our veterans. But I think there's a piece of that that's not missing. But, you know, when you send out a text, you know, what about the veterans that never opened up the text or never responded? And how do you get feedback on, are they in fact getting the information? And then I still think there's some over-reliance on using their website. I think, you know, thinking that a veteran is going to wake up in the morning and go, you know what, I'm going to log into the VA website and just see what's going on here. And that's probably not the best information exchange. But I do have to compliment the Secretary on, in fact, amping up, you know, the exchange with the veteran service organizations. He's doing a good job. Some of the data that's coming out now, and we've been asking questions about that. You mentioned that already about perhaps certain minorities being disproportionately affected by COVID-19. I would say veterans of color and perhaps women are those kind of categories. And so we're asking for more data, you know, on that so that we can in fact help and assess where we can make a contribution as well.
We have a few minutes left, and I want to kind of get through some other issues as quickly as we can. Mental health issues among your members. Has that become an issue?
You know, I don't go out and ask anybody, you know, I mean, that's usually pretty private with somebody if they're dealing with mental health. But what I can tell you, though, again, is I think, again, the VA's approach to mental health and then amping up the telehealth opportunities for mental health has made a huge difference. I mean, we are hearing positive feedback from that. I even think that the Secretary might have mentioned in a recent testimony that telehealth itself, not just specifically to mental health, but telehealth itself is a wave of the future. I certainly agree with that. I've even participated in telehealth, and I kind of like it. You can get a prescription and everything, just by an appropriate conversation with a qualified physician like this. So that's good. Now, what I would say though is, I would have some concerns about what I'm hearing about how much of you would call it the resources that Congress has given the VA, how much of that's really been invested, in the mental health area. We've seen something like 16,000 new employees brought on. I think mostly full-time employees. But of that 16,000, how many of them are actually in the mental health capacities versus some other aspect of it?
I'm trying to get a breakdown of this hiring, which I'm encouraged by, that the VA has used its emergency hiring authority
Right.
pandemic to really fill some of these slots. I just want to plug the Veterans Crisis Line as a follow-up. It's open 24/7, and it's 1-800-273-8255 for any veteran that's experiencing emotional distress that it's serious, or even not so serious. I want to encourage veterans to seek help, and your members to seek help if they need it, or if they know of a veteran that needs help. This is a resource that's available. It's 1-800-273-8255. Select option 1, or text 838-255. We just have a couple minutes left. I want to give you a chance to add to. We got many wins for veterans in the HEROES Act. We just passed the House. What legislative fixes might you be? This is your chance to kind of push it in the few moments we have left.
Well, Chairman, I think we were just part of a group under the military coalition that just forwarded a Four Corners letter, I think, that came through some survey and some reflection from all the veteran service organizations that are part of the military coalition about, where you can help like this. I think the number one issue on there was the CHAMP VA program for children. Right now, some children are being basically pushed out of the program, not by their own choices. The fact that they can't go back to school, they're not a full-time student, or loss of employment or something like this. So I think we're asking Congress in this case to review the CHAMP VA program and perhaps extend the eligibility to age 26 versus what its current age status is right now. The telehealth services as well, we've mentioned about the telehealth services, but in some cases under CHAMP VA, you don't get the full spectrum of telehealth. You get like an audio only. So you can't do audio and data exchange, if you're, moving x-rays or whatever other information is like this. So I think we're asking you to look at that. We mentioned earlier about standardization, but PPE, but I think we're asking for, the testing, tracking, and PPE supplies. I think we're all concerned, as I know you are, about the safety of the VA employee workforce, and make sure that, they themselves are taken care of just as much as they're taking care of us as well. The disability benefits questionnaire, the VA came out and kind of disqualified DBQs, and we think that should be brought back up. I've got a lot of feedback about how not having these public-facing DBQs are, as far as trying to get kind of a claims established. And then the last part is some aspect of a rapid retraining program. I think there's an issue right now, a program called Vet Tech, and we're asking Congress to consider what they can do for veterans, to kind of get them into a new qualified occupation. Many of them are displaced, not by their own choice, but certainly by the outfall of the pandemic here and just the financial turmoil that our nation's facing right now. So what can we do to get veterans back into the workforce? In some cases, that's retraining. And so where we can help along those lines as well.
Well, thank you. Thank you for mentioning all those issues, and I'll certainly review them with my staff, and always a pleasure. I'm sorry we
Yeah.
can't spend more time, and I'm sorry it's under these circumstances. And let me just say, I want to tell you that I want to touch back on the contact tracing, the testing, contact tracing, um, and also I think isolation and housing. Um, I'm concerned about when veterans uh, uh, do test positive. They may not be serious enough to keep at the facility to be. Um, uh, I'm forgetting the word, but they have to be at the facility,
Quarantined.
quarantined, or actually the inpatient care at the
Mhm.
VA, and they're sent home. Um, there, I understand the VA is like, it's no longer their responsibility. They don't do contact tracing. It's usually the county or the state that does that. Um, I think there has to be I mean, I get the numbers on how many veterans are infected, how many of them have recovered, how many of them died. Uh, but the case management after that is a bit of a disconnect. But that leads to a whole big national discussion about
Yes, sir.
a contact tracing workforce. I've done a video with Johns Hopkins University. They've developed a 6-hour training course for contact tracers. Many of our veterans and many of your members, that may be an appropriate place with their skill sets to think about being part of that workforce. Because I think we really got to ramp that up, in my
Yes,
opinion.
sir.
So, but anyway, I've got to say goodbye. Aloha. Aloha.
Hello.
It means hello and goodbye. And thank you so much for spending time with me today.
Thank you, Chairman. I appreciate this. And thank you for your leadership again.
You're welcome. Thank you for yours. Thank you.
Thank you.